This is week 5, Organogenesis, Skeletal, Muscular, Nervous Systems, and Limbs, part 2. I would like to start part 2 with the congenital clubfoot. It is a relatively common birth defect, about 1 in 1,000 births, and its name is Talipes qualivarus. Its most common musculoskeletal malformation. The sole of the foot is turned medially and the foot is inverted. 50% of the cases are bilateral. It occurs twice as frequently in males, and it is believed to have a multifactorial inheritance. It is treated with casting or taping, and individuals who are born with this are able to overcome this malformation. In fact, if one looks at some of the people that have had this disorder, these include Kristi Yamaguchi, the figure skater, Troy Aikman, the football player. Here is a picture showing you a normal foot versus a club foot. I would like to look at split hand foot malformations. In actuality, we've looked at this before when we were looking at the case study on Grady Stiles. In this condition, you have the absence of one or more central digits due to failure of development of one or more digital rays, and the hand or foot is divided into two parts that oppose and curve inward. It's rare. It affects about 1 in 20,000 live births. It is inherited as an autosomal dominant disorder with incomplete penetrance at about 70% of the time. The defect originates in the 5th to 6th week of development when the hands are forming. This is a picture of a mother and her 2 children who, and this is actually in 1912, who actually have this condition. In looking at developmental dysplasia of the hip, it occurs in about 1 in 1,500 newborns. It is more common in females. And what can happen here is that the joint capsule is very relaxed at birth, and there's underdevelopment of the acetabulum. If you all remember, the acetabulum is the socket in which the head of the femur fits into. It's a ball and socket joint, and it's extremely important that it is stable. If you compare it to the ball and socket joint in the shoulder, in the glenoid cavity with the head of the humerus, that's a shallow socket versus the deep socket of the acetabulum. And the acetabulum needs to be stable so that one is able to walk on 2 legs. Dislocation almost always occurs after birth, and there's 2 basic causes. 15% of the time there's an abnormal development of the acetabulum, which is common after breech deliveries. And also there's just a generalized joint laxity. This type is dominantly inherited, that's associated with the congenital dislocation of the hip, which follows a multifactorial pattern of inheritance. So it's 2 things happening in that case. This slide is showing you a comparison between the head of the humerus fitting into the glenoid cavity versus the head of the femur fitting into the acetabulum of the os coxae or the innominate bone. And what you see here is that when you're looking at the hip, it is built for stability with the deep cup, whereas the shoulder joint, which can be easily dislocated, is built for mobility. Let's look at congenital hydrocephalus. It's basically an imbalance to reabsorb cerebral spinal fluid at the same rate that it's being secreted. It can be congenital or it can be acquired. Congenital hydrocephalus is present at birth and may be caused by either events or influences that occur during the fetal development or genetic abnormalities. Acquired hydrocephalus develops at the time of birth or at some point afterwards. This type of hydrocephalus can affect individuals of all ages and may be caused by injury or disease. So we're looking at a blockage, and there's many different reasons why you could have a blockage. And hydrocephalus could result from something like a stenosis or a narrowing of the aqueduct of Sylvius, which is a channel which connects the 3rd and 4th ventricles in the brain. We'll be looking at that in just a moment. Could also be caused by developmental disorders such as those associated with the neural tube defects, spina bifida, and encephalocele. Other possible causes include complications of premature birth, such as intraventricular hemorrhage. And then let's not forget the teratogens that we looked at in the TORCH studies. And if we look at cytomegalo virus and also toxoplasmosis. In looking at the flow of cerebral spinal fluid, we see that the choroid plexi, which are capillaries, secrete the cerebral spinal fluid from the blood onto the tops of the ventricles. And there are 4 ventricles, 2 lateral ventricles, and a 3rd ventricle, and a 4th ventricle. These are chambers within the brain. So when the choroid plexi secrete the cerebral spinal fluid, and it goes into, at first, the 2 lateral ventricles, the cerebral spinal fluid flows through a hole called an interventricular foramen to the 3rd ventricle. It then moves from the 3rd ventricle through a channel called the aqueduct of Sylvius to the 4th ventricle, and then from the 4th ventricle to the central canal around the spinal cord, back up to the brain where it is reabsorbed into the venous blood. It's important then to remember that as the blood is flowing from the 2 lateral ventricles and then into the 3rd ventricle, that at the tops of the 3rd ventricle, we have choroid plexi there too, which is secreting more cerebral spinal fluid. And then when we go through the aqueduct of Sylvius into the 4th ventricle, at the top of the 4th ventricle, we're also going to have more cerebral spinal fluid. So if we do not get rid of, or we do not change how the cerebral spinal fluid is flowing so we don't accumulate a lot in the ventricles, then we can stop the pressure on the brain, which can lead to blindness and also can lead to loss of cognitive ability. This is a slide just showing you the 4 ventricles. You can only see one of the lateral ventricles there, but the 4 ventricles in the brain, and you can see the fluid buildup causes the head to get bigger, and it also causes headaches in the children. In this slide, which shows you the cerebral spinal fluid flow, we can see the ventricles, the right lateral ventricle, the left lateral ventricle. We can see the 3rd ventricle, the cerebral aqueduct or the aqueduct of Sylvius. The one thing you cannot see here on this diagram is you cannot see the interventricular foramen going from the 2 lateral ventricles into the 3rd ventricle. But you can also see the choroid plexi, which you are designated as the tops of the ventricles. We do have some that are also in the central canal, but not that many. And then we can see here how it goes, the cerebral spinal fluid then moves down the central canal. In looking at cerebral spinal fluid flow, you can also categorize it as being communicating versus non-communicating. And if it's a communicating hydrocephalus, this happens when the flow of the cerebral spinal fluid is blocked after it exits the ventricles. This form is called communicating because the CSF can still flow between the ventricles, which remain open. Non-communicating hydrocephalus, also called obstructive hydrocephalus, occurs when the flow of the cerebral spinal fluid is blocked along one or more of the narrow channels connecting the ventricles. In looking at the diagnosis of hydrocephalus, we could see that in some cases the babies will show on ultrasound prior to birth that they have hydrocephalus. In infancy, the most obvious indication of hydrocephalus is often a rapid increase in head circumference or an unusually large head size. Other symptoms may include vomiting, sleepiness, irritability, downward deviation of the eyes, which is also referred to as sunsetting, and seizures. As far as the treatment for hydrocephalus, the first thing you want to find out is what actually is causing this problem. Is it an infection? Is there a blockage caused by a narrowing of the channels? etc.? Is there bleeding? So hydrocephalus is most often treated by surgically inserting a shunt system. The system diverts the flow of the cerebral spinal fluid from the central nervous system to another area of the body where it can be absorbed as part of the normal circulatory process. This is a skull that was recovered from many years ago that had hydrocephalus, and it is believed to have been one that a child who suffered from stenosis of the aqueduct of Sylvius. And this is an X-linked recessive disease. Muscular dystrophy. We talked a little bit about this last semester, but muscular dystrophy is a group of muscle diseases that results in increasing weakening and breakdown of skeletal muscles over time. This group of disorders differs by the muscles that they primarily affect, the degree of weakness and how fast they worsen, and when the symptoms begin. Many people will eventually become unable to work. Some types are also associated with problems in other organs. There are 9 main categories of muscular dystrophy that contain more than 30 specific types. The most common type is Duchenne muscular dystrophy, DMD, which typically affects males beginning around the age of 4. Some of the other types include Becker muscular dystrophy, facioscapulohumeral muscular dystrophy, and myotonic dystrophy. The causes are that these diseases are due to mutations in genes that are involved in making muscle proteins. These can be inherited differently: X-linked recessive, autosomal dominant, and autosomal recessive depending upon the disease. And the diagnosis often involves blood tests and genetic testing. The most common form of muscular dystrophy is Duchenne type muscular dystrophy. Although girls can be carriers and mildly affected, it's much more common in boys. About 1/3 of boys with Duchenne muscular dystrophy don't have a family history of the disease, possibly because the gene involved may be subject to sudden abnormal change, a spontaneous mutation. Signs and symptoms of Duchenne muscular dystrophy typically appear in early childhood and may include frequent falls, difficulty rising from a lying or sitting up position, trouble running and jumping, having a waddling gait, walking on the toes, having large calf muscles, muscle pain and stiffness, and learning disabilities. The signs and symptoms of Becker muscular dystrophy are similar to those of Duchenne, but tend to be milder and progress more slowly. The symptoms for this disorder generally begin in the teens, but may not occur until the mid-20s or even later. The complications of progressive muscle weakness include trouble walking. Some people with muscular dystrophy eventually need to use a wheelchair. Shortening of muscles or tendons around the joints is referred to as contractures. Contractures can further limit mobility. Breathing problems. Progressive weakness can affect the muscles associated with breathing. People with muscular dystrophy may eventually need to use a breathing assistance device, a ventilator, initially at night, but possibly also during the day. A curved spine, scoliosis. Weakened muscles may be unable to hold the spine straight. Cardiac problems. Muscular dystrophy can reduce the efficiency of the heart muscle. And swallowing problems. If the muscles involved with swallowing are affected, nutritional problems and aspiration pneumonia may develop. Feeding tubes may be an option.